Skin issues are another one which I'm not good in treating. So if somebody has related skin issues, then they usually see a dermatologist. And some, for certain things we have no good medication treatment, any medication treatment, and that is the balance issue. The balance issue is a major problem for advanced Parkinson's disease. It causes a lot of morbidity, possibly mortality, and that can only be addressed really by physical therapy and sticking with the safety precautions.
Okay, great list. That may be the most detailed list anyone has offered me. I'll repeat it back to you, and I want to go through them because this whole kind of non-motor symptom characteristic component of the disease is pivotal to come up very often. So I got balance, constipation, hypophonia, emotion. I threw a couple in too that I've heard in other cases. I'm going to confess that to you. Emotionality, cognitive issues, hallucination, depression. Skin I hadn't heard before. So then I just kind of went through them and X'd them out according to what can be, even if it's not perfectly dealt with now. So constipation may be short in difference in etiology. Depression, there's lots of antidepressants. To some degree or another, they are effective. Balance, nothing exists currently. Let's go through these other ones. As you think about the importance of the effect of the disease, the symptom, and whether or not you're able to deal with it relatively effectively as a physician, hallucination.
Yeah, I mean, hallucinations are an issue because the treatment for hallucinations usually counteract the treatment of the Parkinson's disease itself. So it's even though it's probably in different areas of the brain, but pro-dopaminergic drugs will have a propensity to possibly cause hallucinations, whereas hallucinations are traditionally treated with anti-dopaminergic drugs. So that's an issue, certainly, which needs to be kind of, luckily it's not, it's usually when I use an antipsychotic treatment medication in patients with Parkinson's disease, at low dosages they usually work and they don't make the Parkinson's disease visibly worse. So it's, but that's always a concern and the potential of it. And I only treat bothersome hallucinations. So benign hallucinations don't need to be treated. It means usually the patient has insight and is not acting on them, putting himself at danger or putting others at danger.
Really good. So that's a really good case in point of a consequence of the disease that, although it may not be able to be treated optimally, can be treated, and then you have the addition that frequently they're benign hallucinations, so you don't have to necessarily treat them. That was beautifully gone through. Balance, I think we dealt with really effectively. Let's talk about cognitive issues because that one comes up a lot. So when you think about what you do in those cases, tell me a little bit more about it.
Well, the cognitive issues are part of, anyway, the age group of most Parkinson's patients. So in some it may just be mild cognitive impairment of aging, but in others it may be dementia, and it could be dementia associated with Parkinson's disease, but it can also be unrelated to it, so either Alzheimer's disease or vascular dementia, because they're common enough to coexist. I think a Parkinson's disease patient who has cognitive complaints or the caregivers have cognitive complaints about with the patient, then deserves and should get a workup as if the patient did not have Parkinson's disease. So I usually check a thyroid function and B12 level like I would do with anybody. Often get an MRI of the brain with specific quantitative evaluation of the hippocampal formation, which would indicate whether the patient has Alzheimer's or will or is on the way of getting Alzheimer's disease. And then we do have evidence that cholinesterase inhibitors do work in cognitively impaired Parkinson's patients. So they may go on these medications. Theoretically, that may worsen tremor, but it practically doesn't really. So provided, obviously, that the patient is not on trihexyphenidyl or Artane for his or her tremor, because that will certainly or can certainly cause cognitive issues. So that the treatment of Parkinson's tremor may cause cognitive issues, but usually the treatment of the cognitive issues in reverse do not worsen the tremor of the patient.
Yep. I think that's the list, because I don't know enough about skin to talk with you about it. The only other one you mentioned, I think you said, was hypophonia, like a low or slurred voice. Is that what that is?
Yeah, so hypophonia and loss of prosody. So you only speak and has no intonation. It's just going or like this. So again, no medication treatment. Patients go to speech therapy and do exercises for that, and that actually works quite well. Yeah, and the skin issues is seborrhea, so that the skin becomes really fatty, and but again, I don't treat that. I recommend patients to usually see a dermatologist if they have associated skin issues.
Okay, so that's a great list and run through of the non-motor consequences of disease and what you have available to you. So I think we've run through the motor side of the equation, the non-motor side of the equation, and I don't know what remains, but given that we have discussed them, both kind of sides, when you think about the areas that are most difficult for you, so this is putting everything together, not just that there may or may not be a list of great medications, but it's kind of that combination between the side effect itself or the disease symptom itself being significant and also limited ability to deal with it. And you open up the conversation to all of these things on both sides of the equation, motor and non-motor. What is the most challenging area of dealing with Parkinson's at this point for you?
Well, I think it is, oops, no, I lost you here. I think it is for the safety of patients and also for their ability to engage in their normal life as they see it and continue to be able to engage in their life. It is a balance issue. I think that comes up after 10, 15, 20 years of having Parkinson's disease. Not just that it prevents them to engage in the activities they like to, but it also puts them at certainly at a real risk for hip fractures, for head injuries, and whatever it will be, as a result of that. That is the one thing which I'm concerned. In some patients with advanced Parkinson's disease, it's the dysphagia, which we didn't really mention even, and associated risk for aspiration pneumonia, and then, ending up in the hospital that way.
That's separate from the balance issue, though, correct?
Yeah, they would be separate. But if you ask what's the most challenging, when I say the most, when you talk about the most challenging, I see the patients at the severe or end stage of the disease. I don't see the working person was diagnosed last year. They have their own challenges, obviously, with it, coping, early on anxiety, even sometimes before motor symptoms, and for them that is the issue, or depression, or the beginning cognitive problems. But for me, when the most challenging are the things I cannot really influence that well, but I will see the consequences of it, and that is the balance issues, or basically what patients end up in hospital for and potentially even can die from.
Yep. Just taking a final note.
Mm-hmm.
When you think about the areas of Parkinson's treatment currently, and I don't know if there are any, so this is a very open question, where the innovations have been most successful, what kind of things come to mind?
Well, you know, I mean, from the pharmaceutical company's standpoint, they've been successful in bringing out newer medications which really do the same as what has been done anyway.
Yeah.
So I think, you know, and then probably spending a lot of time in marketing drugs to be sold. And I think that's basically my main concern, that this may take away resources from really trying to find a disease-modifying treatment or even cure, but a disease-modifying treatment slowing down the progression of the disease. And I think that's why I'm a little, you know, reluctant, hesitant, and even cynic about these new developments of drugs where now amantadine comes out as once a day instead of twice a day. How much money has been spent in developing that in the clinical trials and the marketing and so forth for this relatively low gain in overall benefit to Parkinson's disease patients. You know, and that's basically, I don't really see that much has been done over the last many years to benefit the Parkinson's community, because the true benefit would be if the resources were geared towards disease modification rather than symptomatic treatment. Unless it's, you know, something which is clearly different from what we have right now. And an example which is not that recent either is like a DBS, like the deep brain stimulation. I mean, that is truly different. It offers some patients a benefit where they wouldn't have it otherwise, or at least a good alternative to their treatment. But in terms of drug treatment, not so much. Yeah.
Do you get to see patients back under your care once they've undergone DBS, once they've had the implant?
Yes. I don't manage their, well, actually, I shouldn't say that. We also adjust DBSs, yeah, but they often go back to the institution where it was placed, unless it's too far away. And so we basically co-manage, because they don't usually, they may decide just to get their device checked every 6 to 12 months and then be managed for all the other symptoms of Parkinson's disease by
Absolutely.
By me.
What kind of experiences do patients have with it that you get to see?
Well, I think there's a fairly positive experience, and I think more patients would do it if it wasn't an invasive procedure.
Sure.
I mean, some people get so scared by the idea of getting brain surgery. It also, you know, it's only being used in patients who are not cognitively impaired, usually, and so by the time patients may decide, yeah, you know, it's time to do something different, they're not candidates any longer. But I saw you were smiling when I was talking about golf earlier. There's a caddy in my area who has deep brain stimulation, has Parkinson's disease for 20 years, and he's still carrying 2 bags, 18 holes. So for some, it's really a huge difference to not probably having gotten that.
Yep, I do hear stories like that sometimes. Doctor, that was a delightful conversation. I really do appreciate the candor and the clarity. It made a few things that I hadn't really sure I was grasped to this point really easy to understand, so thank you. Do you have any final questions for me today?
No, not really.
Thanks again for your time, Doctor. Have a good afternoon.
But yeah, thank you very much.
Bye-bye.
Bye.